Morning. Morning.
Hey, everybody. So if you've already joined us and you want to introduce yourself in the chat box, let's do that. Just name and organization. We'll probably have some new faces in the room today, so we won't take the time to go around and introduce everyone because we have a pretty full agenda. But if we want to use the chat box for that, that's worked pretty well. And we'll get started in just a minute. Lisa, if you want to screen share the agenda for us as we get going, that'd be great. Thanks. Sure. Okay, hi everybody. I see a number of people are joining. It's 10 o'clock. Just ask that everybody, first of all, again, this meeting will be recorded as our other work groups have been recorded. That recording will be available on the website for the planforchildren.org, as well as the agendas and meeting minutes and other materials. That's where we post a lot of this information. So if you could introduce yourself, please, using the chat function, that will help us know who's in the room here today. And just welcome everyone. Thanks for joining us for this first meeting of a work group on short-term solutions to the behavioral ED volume. So I think I know most people on the line, but if you don't, my name is Jeff Vanderplug. I'm the CEO at Child Health and Development Institute, and I'm joined facilitating this group by Tim Marshall from DCF. Tim, do you want to introduce yourself and say a few things?
Sure. Good morning, everybody. My name is Tim Marshall. I'm the Director of Community Mental Health Services at DCF. Appreciate everybody's joining. Yeah, so just for the context, if anybody wasn't a part of the Behavioral Health Urgent Care and Crisis Stabilization Work Group, it was during that meeting last week that there was a spin-off conversation as we were going through the components of what we might recommend for the behavioral health urgent care centers in Connecticut, which we know will not be an overnight process to implement something like that, that a conversation occurred that really was right. How do we be more responsive to the current crisis in Connecticut today? So that's how we arrived here. We've got, I believe we have 4 meetings on the books, to at least this one and 3 more, to at least try to see if we can get some concrete recommendations from this group to put forward. And just to be clear, what we're thinking we're doing is putting forward those recommendations to the Implementation Advisory Board as a whole by way of the tri-chairs, and to deliver to the 12 state commissioners and leadership administrators of those 12 state departments that are legislatively provide oversight. And at that point, we can make some decisions to then share with legislators as needed. But again, from that perspective, I think I need to defer to my State Department and other state departments' leadership on that. But I suspect that would be a legitimate avenue to go down. So I'll pause there and turn it back to you, Jeff.
All right, thanks, Tim. If we could scroll down into the agenda a little bit, we'll just give you a sense of what we have planned for today. You could see the work group goals are essentially what Tim said. It's all about short-term solutions. So as we concurrently work on the behavioral health urgent care crisis stabilization idea and model, this work group is intended to think about short-term solutions to the behavioral health ED issue. So we'll spend a little bit of time today. We do have some information on intermediate levels of care, but we also understand that may not, and likely is not, the only solution, and may not even be a short-term solution to these issues, but it is something that came up at our last meeting. So we did a little bit of prep around intermediate levels of care. I'll do a brief recap of where we were at the last meeting for those of you who weren't able to join us at the urgent care work group. And I think we need to spend most of our time, and the vast majority of our time, on number 5 around brainstorming immediate solutions. So Elise, if you wouldn't, Tammy, go ahead, please.
I mean, I don't want to jump ahead. This isn't a specific solution. I just want to challenge us a little bit. I think it's like admirable and makes a lot of sense that we need kind of focused attention on this idea of short-term solutions. But even with this kind of timeline, it just feels like any kind of solution is so far off. You know, if it takes you 4 to 6 meetings to get some recommendations, it gets how many meetings to get recommendations advanced, how many meetings to then execute on those recommendations. It just feels like the timeline is a little far out for what would be like a short-term solution. And I feel like we're kind of using a standard process of work groups and meetings and to you know, kind of, but we need something different. So I just want to challenge us a little bit to think about, as we're thinking about solutions, it's like, how can we expedite the work that, you know, anything that could happen now or soon, and thinking about something with more like a 60-day time frame to have, you know, something happening instead of a 60-day time frame to have recommendations.
Sure, I'll start, and I know Tim may want to respond to, but I don't think that seeing 4 meetings on the calendar presumes that we won't have any recommendations until November 4th. I think if we have ideas and recommendations that we feel that we want to put forward as a group much sooner than that, we absolutely should do that. And our focus should be on the things that can be done most quickly, as quickly as possible. So I appreciate the comment, and I see Carl's hand is up. Carl, go ahead, please.
Can I quickly make up, sorry, Carl, let me just respond also. So I think one of the things, and I do think we do need to jump into the agenda. So there are a couple of things in terms of responding. I think we were intentional about just being clear that we had enough meetings on the books, but we did respond. This is a week later. We were about to show you what we have already gathered from across the state, from what we could hear on a bunch of already concrete recommendations. And what is often unable to be shared, and it's been already a frustration of mine in a number of these previous meetings, is what's going on behind the scenes, specifically about what we could do to shake loose money today from what particular area or another, whether that is pivoting the ARPA dollars that everybody's been so keenly aware of, but also other avenues. And so I'm not at a position to be able to share any of that until it's actually done. But I can tell you that there's a lot of going on behind the scenes to be responsive. So I think we have some things that we could start to deliver after this meeting. So I'll just say that, and I see that, Carl. So you can go ahead, Carl.
Sure. Thank you, Jeff, Tim, and Tammy. I appreciate you sort of setting the stage. You know, when I saw the title of the work group, it was really created in response to the acknowledgement of a crisis in children's behavioral health, particularly in the emergency departments in Connecticut. And I see that this group is really dedicated to coming up with solutions to that problem, but we are not working in a vacuum here. And I felt it was important at the outset, even before we get into the agenda, to try to share a better sense of what we know is already going on to address this crisis. And to that end, you know, I can report that Connecticut hospitals have banded together and established and are coordinating an incident command structure to address the immediate capacity challenges, you know, as we all work together to develop what I'll say are intermediate and longer term solutions to the problem. And through this incident command structure, we are endeavoring to identify improved administrative processes to ease patient flow, address issues related to staffing, which, as you all know, it's a challenge everywhere, engage state contracted entities to supply crisis level response services. And I'm sure that's on your list already, Jeff, things like EMPS, et cetera. Opportunities to explore what the state can do right now with respect to state operated facilities. And we know engagements are already occurring at the governor and commissioner level to talk about that stuff. And then patient transfers are happening. This model we used during the first surge of the pandemic. And while we hoped never to have to do it again, we are doing it again. And so I wanted to assure you that, I'm aware of daily reports on our progress to the state at the OPMN commissioner level on, what happened today and how we're doing to relieve, the burden on our emergency departments, particularly at places like Connecticut Children's, which to a large extent brought this issue to the fore. So I wanted to start by mentioning that things are happening in the short/immediate term. And I wanted to also invite my hospital representatives who are actually doing the work in several of these areas, such as Dr. Fortunati, Dr. Savronsky, Jason Malia, and others, to comment on what I've mentioned with respect to the incident command. So I'll stop talking now. And frankly, if there are other cool things going on to try to address this immediate problem, I'd love to hear more about them. So I'll stop there, and perhaps if I may indulge the group, invite the hospital representatives to talk about the things I've already mentioned. Thank you.
I'm happy to comment quickly. We're grateful that the Hospital Association has stepped up to bring the hospitals together and form this process. It has significantly improved our ability to move kids out of the ED. I think we moved about 7 or 8 kids yesterday to other partner hospitals around the state. And we're grateful for that. However, I think the issue we all recognize is way beyond just the kids sitting in our emergency rooms. It's what can we do to ensure that kids who don't need emergency level of care can be cared for in the community, and that kids who do come to the emergency room have places to be referred to so that they don't have to sit in emergency rooms for extended periods of time. So while we're grateful, Carl, to CHA and all the work that was being done, I think there's a lot more work that can be done in parallel and in concert with the work that we're doing around diversion to address the broader issue of throughput, of lack of access, and getting kids the services and families the services they need.
And this is Jason from Yale. I'll just be very brief. I agree. Here at Yale, we have 40 pediatric inpatient beds. They have been full for months. We have another 20 in our ED, so 60 total here. And our biggest challenge is the same, which is getting people through the inpatient level of care back out. So once they're in, we tend to have a significant portion of them that can't get out just because of the lack of access to longer term in-home care or that short term 1 to 7 day once they leave. They're really waiting for appointments. So I'm hoping that we can really address some of that concern.
So I appreciate all those comments. I think what's getting framed up here is very similar to what we had talked about leading up to this meeting in terms of a framing. And I'm hearing kind of four areas where work needs to be done, 4 areas where we need to come up with short-term solutions. One is the idea of keeping more kids out of the emergency department altogether, particularly those kids of mild to moderate acuity who are not going to be admitted to inpatient and don't need to present to the ED at all. So how do we eliminate ED touch for those young people by doing a better job in the community? Area number 2, in my view at least, is moving kids more quickly out of the emergency department. Again, for those low or mild to moderate acuity youth who aren't likely to be admitted inpatient or don't have a recommendation for inpatient admission, how do we more quickly expedite their discharge from the ED? A third area is for those high acuity youth who are in the emergency department, how do we expedite access to inpatient beds when that's needed? And then fourthly, Jason, I one that I hadn't actually thought of before, but you're mentioning is for those kids who are admitted and sitting in an inpatient unit and are ready to be discharged, how can we facilitate timely discharge from inpatient to an appropriate level of care in the community? So if we think about those 4 pillars, and keeping in mind that today's work is really about short-term solutions, that's kind of how I'm going to be thinking about what we discuss. And I think we should just sort of launch into it with those 4 pillars in mind. And again, let's keep our frame of reference here on short-term solutions, things that could be stood up quickly, building on existing resources, et cetera. Go ahead, please.
Yeah, I just wanted to add, I think I agree with the focus, but I do think that there are pieces that will need to be discussed that are, so in addition to those 4 pillars, we're focusing on short term, but I do think there's some intermediate and long-term things will continue to come up. So I think we're really talking about trying to pull the full package together, short, intermediate, long-term. We're focusing on short-term today. I just want to recap what I heard. Last week, we heard we need to respond to the urgency of need. And then we began with, well, there's already some responses to the urgency. We want to add our voice to that urgency and other activities to that urgency, so that we want to be able to do that. And then again, we also want to echo what we know has been communicated in a number of forums in the last number of months leading up to this moment. We are not surprised that we're here. I mean, a number of us and many people have been saying over and over, this is coming, and here we are now there. And so in the context of that, there was lots of recommendations about what needed to be done. So hopefully we can recap that right now. So thank you, Jeff.
Thanks. Yeah. Sarah, go ahead.
Yeah, thanks. So really appreciate this group coming together. I said in the chat that I really echo, like urgent can't be urgent enough, right? For some, and I think I want to echo what Tammy said about, I think, holding ourselves accountable to short term, making sure that, executive and legislative leadership have recommendations about things that can be put into place. I would agree with the 60-day timeline, right? And that may be, in short terms, not always optimal, right? But there are things I think that we can pilot. And I just wanted to throw a couple of things out there that I've been thinking about and talking about with others. One is, while there's a working group now in behavioral health urgent care, is there an opportunity to fast track a pilot model of something, whether it's not, even if it's not an overnight, if it's a, if it's an almost like outpatient or something, is there an opportunity there? So that's one. Two is, to the extent that there are dollars around mobile crisis, is there an opportunity to think about how to use mobile crisis dollars to, one, create specialty teams that might be needed for kids with a certain kind of clinical presentation or developmental disability. I don't know how much those kids are part of who's stuck in the EDs or inpatient units. Two, to use mobile crisis to really make sure that our mobile crisis teams are able to stay with families and bridge them, not just the first moment of connection, but to bridge them to a next level of care. Three is there an opportunity to use mobile crisis personnel to embed in schools that may be high drivers right now to EDs? I don't have current data on where the kids are coming from that are stuck in the EDs, but obviously we saw school reopen and now more kids coming, right? So are there opportunities that we can think about that really creatively and quickly around mobile crisis? My next category would be, I say this in lots of meetings, I'm still really worried about whether our nonprofit providers have this financial support that they need to sustain the capacity they have at the intermediate level of care, much less increase it potentially, right? So we continue to hear, and I don't have system-wide data, but we continue to hear from individual providers, both hospitals and community providers, that there are long waiting lists at the intermediate level of care, right? And so what's the solution to that? And as Tim said, there's big picture problems there that are longer term to fix. But are there short-term solutions to protect and enhance capacity at that intensive home and community-based level by providing more money to the community-based providers? And are there unspent ARPA dollars that can be used to do that? And I know that that topic's been on the table for a while, but I think there is a direct line to be made between the dollars for the nonprofit sector and our ability to connect families to the right level of care that they need. So I just wanted to underscore that. And my last thought is, you know, do providers have the flexibility of payment to be able to, and reimbursement to be able to work with families on both the clinical and non-clinical issues that are driving crisis at the family level, right? And so are there flexible dollars that providers can easily tap into when they are working with a family who has both clinical and non-clinical stressors? So, you know, those are some of the things that we've really been talking about with a lot of providers. You saw my comment in the chat about schools. I'm really worried there, but those are some things I'd put on the table. I don't know if other folks agree or disagree.
So can we hold, because Jeff, I think it might be helpful to just, let's walk through the quick PowerPoint. So thank you, Sarah, for jumping right in. We just wanted to outline everything that you just said. We already captured on a PowerPoint, and also want to just outline what we've heard. And then when we get into the discussion, what we could do is get people to respond to any particular areas. So we're getting right into the conversation, but just a quick overview here. We wanted to lead with this notion that rates across the entire service system, and particularly at the highest acuity levels, have been underpaid for at least a 20-year period. And so that is a historic issue that has then been compounded by the pandemic. So that needs to occur. And again, these were recommendations that we've heard in a variety of settings. The notion that we need to expand inpatient beds, including the state facilities. We need to expand PRTF. We need to expand and enhance the structures, the interventions within PRTF in particular, and some of the other intermediate levels of care. We need to expand and enhance PHP, IOP, extended day treatment. We need to address the special population needs of the DD, the ID, the substance use, the co-occurring, the problem sexual behaviors, sexual victimization, eating disorder, grief and loss, anger management, trauma. So these are just all, Jeff, I didn't know if you wanted to walk through the PowerPoint or if you want me to do that, but I just think that we wanted to just be sure that we started with a baseline of information for the group to respond to, and then try to get people to focus on, of these areas that we've heard. Number one, are there additional new ones? And number two, of those that we've listed, including the additional new ones, which would be the shortest, most effective thing to reduce or to help move kids through?
Sure, I can pick it up from here, and we'll do this quickly because I see hands up, and I know that people have ideas and solutions. So if you want to advance Elise to the next slide. We did take because the idea of intermediate came up, we don't have to spend a lot of time on this, but if questions come up about the differences between partial intensive outpatient and extended day, just in terms of basic characteristics, we did pull some information together on that. You can see here just basic description of treatment intensity, expected length of stay, and target population. And I'm not going to go through this. We did the same thing for intensive home-based services. Many of which, as we know, have wait lists, but again, other opportunities that are higher level of care than outpatient services, but step down services from emergency department or inpatient hospitalization. Next slide. And so this just kind of gets us into and framing the potential short-term solution conversation. And I think this is an important first question to ask. Let's just say that, you know, millions of dollars are available today. And if we had increased capacity with sufficient rates, I think this is a good question to ask, what percentage of kids that are currently stuck in the emergency department would be able to be discharged to any intermediate level of care? So let's just think creatively about that. And then we'll jump into number two after that. Sarah, I see your hand is still up, but it might be from previously. Okay, so Frank, I see your hand if you want to kind of jump in at this point.
I just wanted to echo my agreement with Sarah's comments, and that with hospital-based solutions. One of the things we heard yesterday on the incident command thing on adolescents is staffing shortages, really nursing staffing shortages. So even if we were to come up with some way to increase beds, it's going to take time to staff those beds. And the ideas of thinking outside the box about how to improve out of hospital care and even repurposing things like the Children's Center of Hamden indicated they have beds, maybe repurposing that for different for kids who are really on the cusp and sometimes don't really need to be in the hospital, but they're getting admitted to the hospital because there's not sufficient outpatient care. I think that's what we really should look at, and just echoing agreement with Sarah's comments.
Thank you. I'm going to call on Jason, but I also want to tee up Sarah Becker as well, because I know she dropped something in the comment box offering something for mobile as well. So let's go with Jason first, and then Sarah, I'm going to put you on the spot, calling you next.
Yeah, just to answer the question that's laid out right here, I think that there, I'm speaking of our facility here where we have pretty robust care model for behavioral health. But we still do admit probably about 10% of our ED patients because there is a lack of 1 to 7 day care. So for us to be able to send someone home, knowing that the next day somebody can be in their home, that's a huge huge gap right now. And those patients end up getting admitted many days because those services aren't available. And that also applies, it's a double whammy. It also applies for getting people out. We have SOLNA issues, but there's also a fair number of people that are discharge ready, but their outpatient follow-up is not ready. It takes 5 to 7 days to get in, sometimes a little bit longer, sometimes a lot longer. But having a mobile interventional program that could respond to people's homes within 24 hours would significantly free up some of the inpatient beds, leading to not needing to increase the number of beds, and would be able to get some of these kids that are taking up beds in the first place from never having to go inpatient. I think secondly, that's that first part. The second piece is where mobile, I think, if we really put a very strong push to get the police and schools to use a mobile program just the same as this, they wouldn't have to send them to us in the first place. The only reason they're coming to the ED, and I think Tim or Jeff, you said this in one other meeting, the only reason they come to the ED, they have no other option, right? The only place that takes care of behavioral health if you have a crisis in the moment. So leading somebody to another resource that they could get care within 24 hours, I think could significantly free things up very short term.
That's great. Thank you, Jason. I think that's a very good bridge and segue to Sarah to talk a little bit about mobile. And I know there are others on the call as well that operate mobile programs that we can kind of explore and think creatively about that. So let's go to Sarah first, and then Anne, I see your hand up after that.
Okay, well, thank you very much. And there are other mobile crisis providers on the phone. So this is certainly maybe a worse crisis than happens sometimes, but this does happen every fall and spring. So as others have mentioned, we certainly put some thought into be as helpful as possible. In the immediate, like today or tomorrow or this weekend or whatever it is we would like to do, I would like to propose that we are getting referrals, certainly from CCMC. We had about 38 from September 1st to October 3rd or something like that. I would like to propose that we free up 4 on-site automatic evaluations right at the emergency department, Monday through Friday, because that's when the need seems to be the highest, and at least 2 on each weekend day. So from my mind, that would be, 24 evaluations set that we could evaluate. This would be kids identified as potentially ready for discharge, maybe not, maybe yes, and then follow up care in the community until they get linked to something else. So that may be helpful to folks, and that wouldn't, in addition to that, we would certainly be available for deferred mobiles, meaning if a parent preferred to be seen later on that day or within the next 24 hours, we would be happy to do so. So maybe that's helpful some way in this. some people in this call may or may not be aware that some years ago, I want to say maybe 4 or 5 years ago, I just can't, maybe it was 6, 7, I've been around for a while. But there is what a position is called as a facility liaison position that DCF had attached into mobile crisis, which allows for some really creative, like a really creative asset to help just with this type of thing with the emergency departments. Some folks aren't aware of that. What that would allow is something like increased capacity or potentially more intensive, not just potentially, it's set up to also provide more intensive help to these really high-end kids who are in the community. So that can be a more sort of intensive, potentially even longer-term solution for some of these kids while they're waiting for access to an intermediate level of care. So I don't know if any of that is helpful, but that's some that at least this particular team is willing to try to do.
So I appreciate
tomorrow,
that, Sarah, very much. I think that, with the time, I would love to hear a response to that after Anne.
Okay, sorry.
No, it's fine. I imagine that we wouldn't get through working through the details of making that work on today's call, but I
Take
do
a minute,
at
yeah.
a meeting after today, sometime later today, or as soon as possible, to really explore the details of that would be very, I think, prudent. Anne, go ahead.
Thank you very much. There were a couple of things that were said that I would just like to address from a slightly different perspective. One, we did hear from Dr. Malia, we heard about the the need to make sure that there could be immediate support for the child and family upon discharge. And so one of the thoughts is that, we need to expand the role of neighborhood service providers of both clinical and non-clinical supports to those youth and families at discharge. Also, to make sure that we can have adequate family support to reduce relapse and loss of therapeutic gains. The other comment that I would like to make is around making sure that we're addressing the role of schools as a driver of emergency room visits. I think, again, that is an opportunity for us to take a look at how we can tap into some of the neighborhood resources that are out there that can intervene. And in that regard, to take a look at how we can reduce some of the barriers between cooperation of schools and community providers.
Thank you, Anne. And I think, let me just very briefly, and then Sherry, I see your hand. I think the issue of schools is a really critically important one. I think they're making a lot of referrals to mobile. They're making a lot of referrals to the emergency departments. They're making a lot of referrals everywhere. So clearly there's a significant need. I will say, and I again invite mobile crisis providers to speak to this, but our experience working with mobile over the years is that just placing a mobile crisis clinician in a school is not often sufficient to address the issue, because unless you change culture and current practices at schools, what ends up happening is they use a mobile crisis clinician in the same way that they might use a school-based health center clinician, and just sort of like make a determination, send a child to the ED, and then when the child comes back, then they make a referral to the mobile crisis clinician that's embedded in their school, instead of using the mobile crisis clinician more proactively. That doesn't happen everywhere, but I think there are good examples of how it's worked well, but it would require culture change within a school to make that work well. So I'll pause there. I see Sarah's kind of nodding her head. Christine, I see your comment. I'm trying to keep an eye on the comment boxes, but let's go to Sherry first and then Bonnie.
Hi, good morning, everyone. I understand we're in a brainstorming session, so I'd like to throw out a few ideas. The community solution that everyone keeps referring to, I'd like to know what some people think that looks like, what type of community solutions. We are in a short-term solution meeting. I know we have different levels, different reasons why children go to the ED. I happen to represent a community of higher level of need, families and children. So I hear talk about EMPS. I have experience with EMPS. I'd like to suggest that EMPS workers could staff the intermediate care facilities if we're looking for a place to better utilize their expertise and training. what we have in the intermediate care facilities right now, from my knowledge and experience, is they are staying longer than they're supposed to stay. So the beds are kept to capacity because the children are not being turned around as frequently as the program is designed for them to turn around. We have, no offense to anyone on this call, a lot of camp counselors staffing these facilities. We do not have trained people that can work with these higher level of need children. I'd like to suggest we could improve insurance payments to qualified trauma therapists, private therapists. I would also like to speak about agency programs where when you have a child going, whether it's in an IOP or an individual clinician basis, they are required to see that agency's psychiatrist. They are not allowed to see a private psychiatrist, even if they are currently seeing a private psychiatrist. The level of psychiatry offered is not helpful. It's ineffective and unsupported. It amounts to 15 minutes a month of med management meeting for the child and the psychiatrist. That's my input on a brainstorming session and trying to keep it brief.
I appreciate that, Sherry. Thank you. And I'm gonna get to Bonnie's hand. Let me just lift up a couple of things in the chat. First of all, Christine, I think a short-term, potentially at least a short-term solution would be to eliminate the backlog of licensing it. So there's a number of clinicians who aren't able to take their licensing tests. We heard about that in a previous work group discussion, and that if we could add workforce capacity by expediting licensure, I think that would help. It's not going to solve anything, but it's certainly going to help to get more people online in the workforce. Bonnie, go ahead, please.
Thank you very much. And my apologies for getting to the meeting late. I was in a meeting where some of these issues were being discussed. My name is Bonnie Rossig. I'm an attorney with the Center for Children's Advocacy. One of the things that was mentioned is the role of the schools, and the very accurate point that because the schools don't have the resources, children who all of a sudden exhibit some issues are immediately shipped off to the ED. And what can we do within the school setting to provide other kinds of support other than getting the children out? And is this a role for, I think we talked a little bit about the role of mobile crisis. Is this also a role for DCF to be embedded in the schools? Because what happens is ultimately these children are shipped to the ED. The parents won't take them home because they continue to be a threat to self and others. And then DCF does get involved and at that point tries to connect the family with resources that are few and far between. And so perhaps, and it is true, the schools have an incredible task. However, one of their tasks is also ensuring that children access education. If they are in the ED, they are not learning. So is there a way that we can embed staff in schools to support them and direct them when these incidents occur?
Thank you, Bonnie. Sherry, is your hand still up, or is that from before? Okay, I think, Sarah, let's go to you next. Thanks. And then Alice. Sarah, you're on mute. There we go.
Sarah Becker. Okay, because Sarah Egan, she's on the line as well.
Sorry.
Okay. One thing I'm always struck about is that, for instance, if there's 40 youth at an emergency department at any one time, that ultimately there's a group of kids who are discharged home. And sometimes, sometimes they might stabilize in the emergency department. But I often wonder if there's like process improvements that can be made to help get children out very quickly, thus reducing that overcrowding. I do know that in some emergency departments, there's that requirement for a real reason, I'm not doubting it, to have a psychiatric, at least touch base or an evaluation, and that the psychiatry itself, there's only so many psychiatrists to go around. So that might be some piece of it. I do want to say to the school issue that that DCF had and others had recommended really collecting the exact schools that are high refers to the emergency department. So that information is becoming known. A little known fact that we found some time ago is that the schools that were really high refers to the emergency departments almost always were also high refers to mobile crisis. So it's not, with like extremely rare exception. So to know there's sort of a co-entrenchment, but perhaps there needs to be more still within the schools. There clearly does, but that was a little known, I think, fact or finding from that. That's it.
Thanks, Sarah. Alice, please.
Hi, thank you, everyone. Alice Forster, Clifford Beers. I think all of these things are great ideas and things that have to happen. I think there's some technical fixes that could happen very quickly. Someone mentioned private provider work. Private providers, because they're not living under a license, are able to go into people's homes or meet them at Panera or do that work. Not that we have a whole bunch of extra providers laying around, as you've heard from the hospitals. Workforce is a gigantic shortage, but perhaps lifting that regulation so that we can do better outreach in the community with our families might be, you know, a temporary fix. The other thing is the ICAPS rates are fine, but the ICAP length of stay is long. And Gary will say, well, where are we going to get the ICAPS workers, which is another issue. But if we could expand ICAPS for a period of time during this crisis, where we can actually build, those of us who are not ICAPS providers can expand on that work, that would allow for a little bit longer time. The other thing is the whole, on a nationwide, the whole movement of ambulance services is really taking a new look at, rather than just picking up at somewhere and bringing them to the hospital, of doing some intermediary urgent work. And AMR, I know down here in New Haven, has a federal grant to do some work on that, that perhaps we might be able to bring in that organization, because I know from our own experience, the kids in the schools who go to who wind up in the ED, the schools just want the kids gone. So could there be an emergent space, an urgent space, not an ambulance where you're strapped to a bed, but some sort of mobile unit that could go, that could remove the child off of the school property, or even just be in the, in the lot, and then transport the child to the home if that seems to be, the child is de-escalated. And then lastly, I want to echo Sarah's advice. Having ABA or with behavioral tech specialty teams. I know that you've been working, Mobile Crisis has been working really hard on working with children and families with autism, but to have pre and post hospitalization mobile teams for folks living with IDD or autism could be, rate like that I mentioned earlier, but to really wrap around. I don't know what the percentage of the kids are who are in the ED who are living with that, but to have a specialty mobile teams that are really trained up and supervised to be able to handle that, including behavioral techs. So anyway, those are just a couple of brainstorm ideas. I think ICAPS is, Sherry, you're right. There's no one model that works, but the thing that does work is the rate when you're a provider to be able to afford to send folks out. I'm sure it could be higher too, but the rate we get in office, we're only allowed as private providers, nonprofit providers, provide services in office in a licensed space or EMPS. There's no intermediate level for those of us who don't have ICAPS. And sometimes our kids need to be met at Dunkin' Donuts, or families need, something in the community. And the ICAPS rate is at least usable. So I'm sorry to answer your question that was in the thing, and I could be wrong from,
Thank you. That was very helpful. Tim, go ahead, and then Jason will go to you.
Yeah, so I guess there's a lot of conversation and suggestions around mobile crisis, and I just want to kind of put a plug in for that group of folks. For those who are not aware, we have 6 DCF contracts with 6 providers. We have 14 sites around the state. They do a fabulous job. We have 4 of the 6 programs on this call. We have a couple of executives, a whole bunch of managers. I just want to say we have historically done a tremendous amount of work outreaching to the emergency departments historically and tried a number of pilot projects. We have also done that with schools. Just want to suggest that we have been outreaching to schools at the request of DCF for a number of years. We ask the providers on a routine basis. They're all very familiar with their largest schools. They're very familiar with the schools that use them most frequently. They're very familiar with the schools that use them least frequently. They do outreaches after outreach after outreach to the schools that use them infrequently. The data, specific, concrete, strong data, exactly which schools are sending kids to ED. We have only had a couple of opportunities to get that from hospitals at different times as a result of a pilot in particular with CCMC a few years ago. But that's data that is hard for us to get when we don't know who is sending, schools sending. So that would be a piece of information that would be useful to the system. I just want to suggest that any of the suggestions many of people have made, we might need or might suggest a conversation specifically between Yale and CCMC and some of the mobile crisis providers on how to maybe put into action some of the suggestions. In the past, outposting at hospitals hasn't been utilized. In past, making themselves available on a routine basis has not always been utilized for lots of different reasons. So again, we're at a different moment. So maybe that's a different opportunity for us to respond to. And then the notion, Alice, that you just mentioned, I think is really one of the concrete ones that would come along with the Behavioral Health Urgent Care Center, but maybe it's something we can look at in the intermediate session, and that is to get something on the books that would in fact allow EMTs and ambulances to be directed to a location to be determined in each area or in at least a couple areas of the state where some of the assessments that mobile crisis does on a routine basis could occur. I mean, mobile crisis does an excellent job. They 20,000 calls a year, 16,000 episodes of care a year, 25% of those kids are often suicidal ideation. The mobile clinicians do a really great job and they have quite of expertise. That said, they're not immune. The programs are not immune to the vacancy issue right now and the challenge of keeping things staffed. So I just offer that up, and I see a lot of the executives shaking their heads that they're open to these kind of conversations. So we're here, that they're here to assist and support in any way. So thank you.
Thanks, Tim. And let me just pick up on Jerry's comment that calling 211, we do hear this from time to time as well, that it takes too long. Oftentimes when you dig into it, the 211 system is set up, dial 211, press 1 if you're in crisis, press 1 again if you need to talk to mobile crisis. And when people are often waiting for a long time on the line, it's because they didn't press 1 and press 1 again. And it's a little clunky. There's room for improvement there, but if you press 1 and press 1 again, usually you jump the entire queue at 211, you go right to a mobile crisis intake clinician, and then spend a couple of minutes on the phone with them, and then warm transferred over to a provider site. So the overarching thing here is, I think, education to the community and families about mobile crisis is kind of one of those forever and always things, because every year you have a child that's 17 that kind of ages out of the mobile crisis age range. You have a 6-year-old that becomes 7, and you have a new cohort of parents to educate. So it has to happen all the time. And that we have to consider how we can get more information out there about mobile. Go ahead, Jason, please.
Thanks. I was just gonna comment. I think that's very important, and I like the couple suggestions on what I think everybody's referring to as community paramedicine, which is a new model of care, at least in Connecticut, and utilizing that reimbursement model that's already in place or being worked towards, and taking those people and using them to do the things that they can do, respond to a school, take somebody home, be met at the home with mobile crisis. If that's something we can stand up in, weeks to months, that seems like a huge fix to start. I think additionally, Sarah, you had mentioned about in-hospital treatment. I don't know who does what here exactly as your background, but we have a team of 6 social workers that just do our behavioral health and our ED at Yale, and they are the most instrumental part of our throughput. If you're getting discharged home, for the most part, you can get in and out within 5 to 6 hours in our ED, as long as we're not completely overwhelmed, just due to the strength of the social workers. And what I would love to see is, to Tim's point, perhaps some work with that group, our care coordinators, and same for other hospitals, to make sure that we have all the necessary connections to the resources. I do worry sometimes that the list is growing and very large, and we leave it to these people who are so knowledgeable to make sure they know every place they could possibly tap into. And many times, just because of the amount of patients, they don't have time to kind of run all through those different ideas. So if there's a way in the very short term of helping with coordination of some of that, that would be huge for us as well. And then ICAPS mobile, but Solnit is one of our issues right now. I have 13, 14 kids waiting to go to our inpatient beds, but we have 5 for our low age group, but we have stuck in the ED, and we have 5 in our inpatient unit that are ready for discharge waiting on Solnit beds. So, just with sending them to the place they need to go, we would relieve ourselves on the ED side. And that's why I think people keep saying there's not necessarily an inpatient bed shortage. If we can get the people out that should be out and get the people in that should be in, we may be in a good position. Maybe we need a few more, who knows? But I think if we can figure out that flow better, and really work on that in the very short term of weeks to months, that's going to be our saving grace. No one's going to build stuff new. I'll be honest. No one's going to do it. So I think that definitely hitting the nail on the head for that one.
All right. Thank you, Jason. And I see a lot of heads nodding there. Sarah, I think you have your hand up too.
Sarah Becker again, I think. One thing, I sometimes wonder if there's untapped things out there that we're not always aware of. So for instance, we have a DDS program for kids who are in urgent need of sort of, in-home care and behavioral help. And right now we have 4 current openings, actually 5. So I just don't know if resources like that are known. We're sort of stymied sometimes. Like, we know there's urgent need for often kids in emergency department, but I'm not sure, like families are always calling the DDS helpline for something like that. I do love the idea of, like, right now, that could happen if there's any kids stuck that fill into that category. There are also, I love the idea of the creative partnerships. And I think you said the okay, I forget the end of that sentence.
Paramedicine model.
Oh, great. So I know right now, like, we're doing a partnership with the city of Hartford that's likely to take off shortly, of really, as they're being called to respond to things, diverting or just having crisis folks out there, sort of meeting them where they're at, or hopefully going instead, and hopefully doing things like that to divert from going to emergency departments.
Can we just stay on that topic of community paramedicine for a moment? And Anne is asking if the neighborhood grassroots providers who are not currently under contract with DCF, if this community paramedicine model has relevance to those organizations.
Yeah, absolutely. Oh.
Go, no.
I think that AMR, I'm sorry.
No, please.
My hand up. In conversations with AMR, they are hiring social workers to ride along here down in the New Haven area. It's problematic though, because if you put one social worker on one van, you may not get the EMPS, the calls for behavioral health. And, but they are piloting various things. And I think, and there's an opportunity for private practitioners or subcontractors or consultants who are licensed to be able to join in on that. And that's something that we should look into. I think the CAHOOTS model or the police diversion model is also sort of looking at this. Maybe Sarah, that's what you're talking about. I think of what maybe Hartford's doing. I know Norwalk is doing that. And getting peer counselors on board is definitely another sort of model for that police behavioral health diversion. So, and I think your point is well taken. How do we involve more people from the community? Thank you.
I'm going to give Bonnie a quick last word, and then I want to turn it over to Tim for the last few minutes we have, because I've asked if he could kind of summarize and lift up the things that seem to be rising to the top from today's discussion. So Bonnie, go ahead, and then Tim will wrap us up.
Thank you. I mean, when the whole issue for so many of the providers is the community resource. I assure you that if folks in the ED or even in the inpatient beds felt that there was a community resource, that they would be more than happy for those kids not to be in the ED and not to be in beds necessarily. If there's a disconnect between what's out there and what the inpatient facilities have information about, but that's generally, not my understanding that those resources are few and far between. And also, there still may be a disconnect over what is available in person versus what is available remotely, because for many of these children, the remote option is just not, a workable therapeutic model. So I think generally the consensus from my experience is there is not, there are not enough beds, there are not enough community resources. So, I mean, perhaps more effectively using the resources we have, or, providing information, but I think people are feeling that is a resource that really needs to be expanded if we're to appropriately support, children in facilities.
Okay, great. So we have just a few minutes left. So I just wanted to kind of summarize what we've been talking about. And I like to offer up, and I'm going to actually put a couple people on the spot here, but I'm hoping you'll go with me for a second here. In this whole arena of kind of the paramedicine, I'm putting that in air quotes, paramedicine-like, and pairing that with potentially some creative solutions. I'm wondering if Carl, through you and your contacts with Yale and CCMC, I'm looking at Gary Steck and Alice Forrester. I'm wondering if at least the beginning of those folks can get together and maybe have some conversations around potentially some creative solutions about utilizing mobile crisis in that realm. And if we could get together more quickly in the next week or so to just make a much more concrete plan around maybe some concrete next steps there. Let that evolve and see if we could come up with some maybe longer term, but we probably can utilize resources that are available today. Wheeler under Sarah Becker offered direct support to CCMC for direct evaluations. I know space and other issues sometimes get into the way of that, but I think that we'll again want to kind of visit that. Some of the other areas I think we need to, again, continue to pay attention to. We want to, again, put a whole package forth, again, highlighting the short-term responses, but again, not to pay attention to some of the background is important, is important. So we can't lose sight of it. So the rates continue to need to be an issue and need to be addressed. The connection to care, as Bonnie just mentioned, I do think, because we do get a sense of this once in a while, that in fact, some amount of that, how much of that is it 10%, 20%? I don't know, but there is at times a disconnect. So available slots, as Sarah Becker just mentioned, for one program, if those were known in some of the EDs, then they would be filled, I think. So I think there is some issues around connectivity. Again, it may not be huge numbers or percentages, but probably need to do that. So, and then lastly, I would say that what would be hugely helpful, we did do some preliminary outreach to some hospitals and to the partnership in trying to get some data about the current situations. We will ask the hospitals if you could help us out with whatever information you have on the kids stuck in your system today. The better we know of what their needs are and what the clogging is more concretely. So we have heard of it a lot by what you all are telling us. We have surmised it by what we're hearing, but it would be nice if there's at any given time 50 kids stuck, what percentage of them are different, have different levels of need, et cetera. How many are DDID, how many are waiting inpatient, et cetera, et cetera. So those would be helpful pieces of information. So I'm going to presume Alice and Gary, you're okay. I saw a thumbs up from Carl on that. And
I would invite Michael Tercio from AMR to participate if that's okay with you.
Sure.
I'm doing the email right now, invite. Thanks.
Sure, that would be great. And by the way, that's no exclusion to any of the other mobile crisis providers. I just am hesitant to commit you when your executives aren't here. But I do know that your executives are quite committed to the work also. So there may be other opportunities around the state where some of this kind of community-based mobile crisis hospital partnership kind of activities can occur. And essentially it kind of, we're also, the nice piece about where we arrived, I think, is it kind of does lay the foundation for some of the bigger, longer term work that we're looking to do. So I'll pause there, Jeff, and see if you have anything to add.
No, we're out of time here. Just a reminder, our next meeting should be on your calendars for the 14th, next Thursday at 9 o'clock. Carl had asked that we send out the slides, meeting minutes, which we will do. We normally post on the website. We'll do that as well, but we will also email to everybody. And just also as a reminder, we include the comments that you put into the comment box in our minutes, and we'll make sure that we pay attention to anything that we didn't get to directly addressing during today's meeting. So look for that from us. Jay, I see some of your questions on that, and we'll see what we can do about answering some of the questions. So I appreciate everyone's time. We'll take these intermediate steps between now and our meeting next Thursday, and hope to see you all next week, Thursday at 9 o'clock. Thanks again, everyone.
Thank you.